Hello, everyone, and welcome. And thank you for joining our webinar today on AHRQ's CAHPS surveys, the rationale for case mix and mode adjustments. My name is Dale Schaller, and I'm pleased to be your moderator today for the webinar presented by the AHRQ, Agency for Healthcare Research and Quality's CAHPS User Network. Next slide, please. We have just a few technical details, housekeeping details that I'm sure you're aware of to review quickly. First of all, if you have any trouble with your computer audio, you can use your phone to call into Zoom by looking for the dial-in number and the meeting ID, or you can have Zoom call you back if you give them your phone number. If you have connection trouble, you can always try to log out and log back in. Most importantly, today, if you have a question to pose to our presenters, you can use the Q&A icon. Note that the raise hand and the chat feature on Zoom are not able to function for you today. So use the Q&A function to pose your question. If you're willing to provide your name and organization, that helps us to know where you're coming from. And finally, we have an event site that you have received a link for in your registration email, and which will also be posted in the chat, which includes the slides for today's webinar, as well as the agenda, as well as bio information on our speakers today. Next slide, please. And our speakers today, I'm very pleased to introduce Jonathan Bakdash, who will kick us off with an overview of AHRQ's program. Jonathan is a social science analyst for both the CAHPS and SOPS, that's the surveys on patient safety culture programs at the Agency for Healthcare Research and Quality. Our main speaker today is Marc Elliott, who is the Senior Principal Research Investigator at the RAND Corporation. Marc is the co-principal investigator for the RAND CAHPS team, funded and sponsored by AHRQ. And Marc also does serve on a contract to the Centers for Medicare and Medicaid Services, or CMS, to assist with CAHPS implementation. And speaking of CMS, we're very pleased that Elizabeth Goldstein, will join us today for the Q&A portion. And Liz directs the Division of Consumer Assessment and Plan Performance at CMS. And again, I'm Dale Schaller, a member of the CAHPS team, and I'll be your moderator for the webcast today. So our agenda, next slide, is pretty straightforward. We'll have welcome from John Bakdash, and then Dr. Elliott will present on the rationale for incorporating case mix and mode adjustments. And we'll leave as much time as possible for your questions at the end, which we will ask you to submit at any time during the webcast. So with that, I'm very pleased to turn it over to you, John, to kick us off.
Thank you so much, Dale. Thank you, everyone, for joining us today. I want to welcome new and seasoned users of CAHPS surveys. The CAHPS program stands for Consumer Assessment of Healthcare Providers and Systems. Today, I'm going to be giving a brief overview of AHRQ, the Agency for Healthcare Research and Quality, as well as some general background information about the CAHPS program. Next slide, please. I'm going to tell you a little bit more about AHRQ. So AHRQ is a science-based agency that's part of the U.S. Department of Health and Human Services. And we are the lead federal agency charged with improving the safety and quality of the U.S. healthcare system. What we do is invest in research and evidence to make healthcare safer and improve quality. We create tools for healthcare professionals to improve the quality of the care for their patients. So it's important to know what AHRQ doesn't do. We are not a regulatory agency, so we do not require the use of our tools, surveys, or other instruments. If there are requirements to use a CAHPS survey as part of a program, these requirements do not come from AHRQ. And AHRQ covers a number of different areas for competencies: health system research, practice improvement, and data analytics. We do really want to encourage submissions of CAHPS surveys for quality improvement, public reporting, and other purposes. And our mission is really to make healthcare safer and better. Next slide, please. And this just gives you an idea of the different aspects that are assessed with patient experience. You can see there are a variety of different aspects of patient experience, including things like care coordination, getting appropriate information, shared decision-making with patients and clinicians. And the CAHPS program measures many of these aspects of patient experience, and understanding patient experience can help with quality improvement using this data. And AHRQ develops and operates these voluntary databases for CAHPS survey data that provide feedback about patient experience. Next slide, please. You can see there are a wide variety of CAHPS surveys and different settings for CAHPS surveys. This includes experience with providers, experience with facilities, health plans, and condition-specific care. And these all assess different aspects of patient experience with these different settings, and how care is delivered. Next slide, please. And here are the essential uses for CAHPS surveys. So quality improvement, as I mentioned before, patient experience scores can be used to determine areas of strength and areas of improvement, also for public reporting purposes, certification and recognition, and then value-based purchasing, which is not necessarily done by AHRQ, but done by agencies like CMS. And patient experience scores from CAHPS can also be used for health systems research. In the next presentation, Dr. Marc Elliott is going to talk about the rationale for case mix and mode adjustment, and why this is necessary for estimating CAHPS scores. So it's my pleasure to hand it off to Dr. Marc Elliott. Thank you.
Thank you very much. Next slide, please. Here's an outline of what I hope to talk about today. I'll be providing a little bit of background beyond that which has already been provided. I'll talk about the purpose and the methods of case mix and mode adjustment. I'll provide some examples drawing from several CMS implementations in particular. I'll talk a little bit about how adjustments typically affect scores, and I'll also talk about some misunderstandings in this area. Next slide, please. First of all, an overview of CAHPS surveys with respect to these issues. As Jonathan noted, among other things, CAHPS surveys provide comparative information about the patient experience dimension of healthcare quality. Sometimes CAHPS surveys serve as components of pay-for-performance programs implemented by CMS or others. And the motivation for what we're talking about today is that in several ways, the survey responses can be influenced by factors that don't reflect the quality of care received. And broadly speaking, these fall into two categories. The response tendencies of people who complete the surveys, ways in which different people respond to the same care differently, and we broadly call those case mix effects. And then also influence of survey protocols, either on who responds or how they respond. Here the idea is that the same person might respond differently if contacted by phone, for example, than by web or by mail. And broadly, we call those mode effects. And the main motivation is that without appropriate adjustments, then differences in these kinds of factors across reporting units, and by that I mean health plans or hospitals, hospices, medical groups, providers, in any way that you aggregate reporting for a particular CAHPS survey, those could jeopardize the comparability of these results. And so the main purpose of this is to ensure that as best as possible, the scores that are reported reflect the performance of the reporting units. Next slide, please. I'll first start by talking about case mix adjustment, and then later we'll turn to mode adjustment. Case mix adjustment, which is also sometimes called patient mix adjustment, particularly in the context of the CAHPS hospital survey, the HCAHPS survey, adjust patient experience scores to control for respondent characteristics that affect responses independent of the care provided. And in particular, it aims to remove the effects of patient characteristics that are not under provider control. And just to give A couple of examples. We know that the respondents with greater educational attainment and respondents who are younger provide less positive responses for the same care than respondents who have less educational attainment or who are older. So one of the primary purposes is to ensure that the scores that come out are as accurate as possible. But there are also important incentives involved in this, some of which may be related to health equity. If you don't adjust, if you don't account for these factors, then there are potentially incentives for different reporting units to avoid enrollees or patients that they think are more likely to provide lower scores for comparable care. And so one of the goals here is to try to eliminate those incentives that might affect the care that people can access. Next slide, please. So broadly, how do we do this? So statistical models are used to predict what each reporting unit's scores would have been for a standard patient or a standard population. And usually the way this is done is you try to answer the question, what score would this hospital have gotten if they treated the average set of patients across all hospitals? Same things for other kinds of CAHPS surveys, removing the predictable effects of things that are not under their control. So bearing in mind, that our goal here is to measure as accurately as possible, I'd also like to talk about the kind of things that case mix adjustment isn't trying to do. So case mix adjustment isn't trying to address by itself all aspects of health equity, for example. So unfortunately, because there are still disparities and inequities across all aspects of healthcare, it may be the case that hospitals that serve disadvantaged or underserved populations, or plans or providers who serve such populations, may actually have truly lower performance after this adjustment. Our first goal through good measurement is just to reveal that and to make it visible so that it can be acted on. The fact that scores are lower for some hospitals, some plans by itself doesn't necessarily indicate a failure of adjustment. But I'd also like to emphasize that we don't see case mix adjustment as the end of the health policy journey, and that once you see where these disparities and inequities exist, there are other steps that lie outside of case mix adjustment in the health policy realm. Stratified reporting is an important tool to be able to see where these things exist. There may be other incentive programs that involve equity-based incentives. There may be quality improvement efforts. They may be payment policy, and all these things are important. But I also want to emphasize that the distinction between what we're doing in the realm of case mix and mode adjustment, and what essentially are the next steps that can be done building from what the information that this provides. Next slide, please. So now I'd like to talk briefly about mode adjustment. So in some settings, but certainly not all CAHPS settings, different reporting units can choose different survey protocols. So for example, in the case of HCAHPS and in the case of hospice CAHPS, different plans or different hospice organizations can choose different survey mode protocols. But that's not always the case. For example, in Medicare Advantage CAHPS, the same protocol is used for all reporting units. If you have different reporting units using different mode protocols, then odds are that you're going to need to account for that in some way. So survey mode protocols can affect how people respond to the survey and the scores you ultimately get in two ways. The first way is who responds. So for example, we know that compared to younger respondents, older respondents are much more likely to respond by mail. And for example, younger respondents are more likely to respond by phone. But there are also, it's not just about who responds, it's also about how the same person responds to the same question, given the same experiences, in different modes. And for example, by phone, and I'll talk about this a little bit more in a moment, people are a little bit more likely than by mail to select whatever the last answer option is that's read aloud. On a lot of CAHPS items, when the survey is administered to you over the phone, you'll hear never, sometimes, usually, always. And that always tends to get selected a little bit more by phone than it does by mail. And without appropriate adjustments, people providing similar care but using different survey mode protocols can have really different scores. And ideally, and this is the case in CMS implementations, for example, mode adjustment and case mix adjustment are used in combination. Next slide, please. So I'd now like to talk a little bit about why the variables that are used for case mix are used, and then I'll talk about why some that one might consider generally aren't used, and then I'll give some later some specific examples of how they're used on several CAHPS implementations, and a little bit about why it's not always the same list for every survey. So what you want to adjust for are things that are not under the control of provider, and exogenous is one term that's sometimes used for that, but which do result in different scores, even when the quality of care provided is the same. And so, for example, patient education, patient age are not things that the provider controls. Now, sometimes there's a little bit of confusion about what's meant by under the control of the provider, so I'd like to make a distinction. So something not being under the control of the provider means literally that, like you can't change somebody's age. But of course you can, and we very much hope that care is made specific to the needs of patients. So, in other words, you can, and we hope you do, customize care for older patients, but the patient comes to you with their age and you can't change that aspect itself. Next slide, please. So there are variables, potential case mix adjusters for which we don't adjust typically, and these kind of fall into two categories. One category is you don't want to adjust something which just reflects a particularly delivery of care model or something that might be a consequence of care. So for example, patient experience tends to be better with hospitals that have higher staffing, but we don't adjust for the staffing level because the goal is just to describe how good the experience is. And it could be that that patient experience is better or worse for HMOs versus PPOs or nonprofit versus for-profit entities. But again, those are delivery models. We're not trying to account for that. We're just trying to measure how good the care actually is. In other cases, you might have something which is related to people's responses, but might be a consequence of care. Length of stay may in part be a consequence of decisions made by the hospital, and so we wouldn't want to adjust for that. Length of relationship with the provider might also be endogenous. It may be that you stay longer with a provider that you like, and that you leave a provider that you don't have good experiences with. So those would fall into the categories of things that we typically wouldn't adjust for. And the other thing is we don't adjust for we only adjust for patient level characteristics because that way we can isolate what that variable does for different patients in the same hospital or at the same plan. If you have something that's at the reporting unit level, then really there's no way to distinguish its effect from the effect from the actual quality of that hospital or plan. And so, for example, we don't adjust for whether a hospital is in New York versus Ohio versus in Nevada. And if one thinks that there's something different between New York and Ohio and Nevada, then you need to find a way to capture that at the patient level and then adjust for that, because otherwise you're essentially stating by fiat that care isn't of different quality in different states, for example, which we know actually isn't the case. Next slide, please. So sometimes we're asked, what, once you sort of go through these ideas of what conceptually you should adjust for and what you shouldn't adjust for, sometimes we ask, well, why aren't they the same adjusters in all settings? And there are some adjusters that you'll see over and over again across various CAHPS surveys. So age, education, some version of language tend to appear as case mix adjusters on most or even all CAHPS surveys. Others are really conceptually specific to a setting. So for example, in the hospital survey, we account for service line, whether it's maternity, medical, or surgical. In the case of hospice care, we look at the primary diagnosis, but neither of those make as much sense, for example, in a health plan survey, where what you're really doing is not asking about a specific event, but rather all aspects of care over 6 months. Another example of how things can differ for different surveys is that while some surveys, like the hospital survey, you're pretty much just considering the characteristics of the patient and the respondent who are the same person. There are other surveys like the hospice survey or the child hospital survey, where we often adjust for both respondent and patient characteristics. And just as an aside, because a lot of what we're accounting for in case mix adjustment is how people use survey response scales, it's often the case that the characteristics of the respondent, even when they're not the patient, are at least as important as the characteristics of the patient. Next slide, please. I'll delve in now a little bit to aspects of the methodology for case mix adjustment. So there are different ways one could do this. The most common way that we do this is using a linear regression model predicting patient-level responses from case mix variables and then also provider intercepts. And what I mean by that is essentially terms that allow every provider to have different underlying mean scores. And case mix adjustment doesn't require a randomized experiment. It's done in real implementation data. And the way that we actually derive these adjustments is you essentially look at the average effect of the adjuster within a given hospital or plan after accounting for the other adjusters. And the kind of sort of last thing in the top half of the slide is the idea that whatever the effect of the adjuster is, the adjustment is the opposite of that. So if this characteristic is associated with responding 1 point more positively, we adjust your score 1 point down, because the idea is to neutralize the effects of how your patients, your enrollees differ from the average, so that we do the thing that we set out to do, which is to tell you what your scores would have been if you had treated the same patients as everybody else. So for these various implementations, there are typically places where you can find the person-level coefficients and the national means, and you can use that to see specifically how the adjustments work for your hospice, your hospital, et cetera. And just the brief intuition of how this works. If you have a characteristic that's associated with less positive responses, for example, being young, if you're above average on that characteristic that's associated with negative responses, then that gives you positive adjustments. Likewise, if you're above average on a characteristic that tends to be associated with positive responses, like getting care in the maternity service line rather than, say, medical or surgical, then being above average on something that tends to be associated with positive responses brings in a counterbalancing negative adjustment. Next slide, please. So here is just an illustrative example of 3 different CMS implementations. And the first one is HCAHPS, the one in the middle is Medicare Advantage, the one on the right is hospice. And you can see that there are both commonalities and differences in what's used here. So you can see that that all 3 surveys use age. In the case of hospice, it's the age of both the decedent and the respondent. You can see that all 3 surveys use education. In the case of hospice, it's the education of the respondent. And I won't go through all of these, but you can see that, much as I described before, you have both general characteristics that really apply to all settings and others that are really customized to the specific setting in which the care is given. And one way to think about this is just like the content of CAHPS surveys adheres to general principles and has some commonalities, but also customizes to specific settings, case mix adjusters really do the same thing. Next slide, please. I'd now like to talk about one specific new adjuster that's been proposed for the HCAHPS survey. So we had a mode experiment to try to investigate new potential content for the HCAHPS survey, as well as a new potential adjuster. And we asked patients, was this hospital stay planned in advance? 61% of patients said no, 10% said yes somewhat, and 29% said yes definitely. When we looked at the data, we found that in many ways, the yes somewhat responses were a lot like the no's, and so we proposed to dichotomize this and to distinguish the people who said yes definitely from the people who didn't. This variable seemed to be understood in the way that was intended in cognitive testing, and a lot of the empirical patterns were similar to what you might expect. For example, patients in better health, patients who came in for surgical and maternity care were more likely to say that their stay was planned. Next slide, please. And what we found, which was, I should also start by saying that this is in the stage of rulemaking at this point, but CMS anticipates starting with 2025 discharges, adding this as a new adjuster. What we found in the mode experiment was that patients whose stays were planned tended to have tended to report better experiences than those who didn't report a planned stay, and so that would mean that to counterbalance that, the adjustment for planned stays relative to unplanned stays would be negative, and we also found that there was a unique contribution. This adjuster captures things that are not captured in other variables like service line and health and age. It's the magnitude or importance of this adjustment is moderate compared to other existing variables. Next slide, please. Just to give you an illustrative example of how this might work. So right now, the average hospital has about 29% definitely planned stays, and the adjustment for top box scores for the nurse communication composite in HCAHPS At least what we saw in this prior data was negative 5.4 top box points. So now let's imagine two different hospitals, and let's say that after mode adjustment and after adjustment for all other case mix adjusters, they both have a score of 64, 64 top box points. But let's imagine that the first hospital is pretty high on plan stays. Let's imagine that the second at 49%. And let's imagine that the second hospital is pretty low on plan stays, more like 9%. Then if you sort of plug into the formulas, you can see that the first hospital's score is adjusted down by about 1 point, and the second one is adjusted up by about 1 point, so that they wind up actually 2 points apart. And that reflects differences that would now be taken into account associated with some of the advantages that a hospital has in dealing with a planned versus an unplanned stay. Next slide, please. Now I'd like to go into a little bit more detail about survey mode effects. So broadly speaking, there are two kinds of effects that we think are behind survey mode effects. And by this, I'm talking about not who responds, but how the same person responds depending upon the format. So one category is what's called social desirability effects. And the idea here is that people are trying to do things that are more approved of, or perhaps trying to please others when they're more directly observed. And so in particular, you expect the biggest social desirability effects for in-person interactions. Phone is somewhere in between. And then, things like written and web formats, you'd expect the smallest social desirability effect. And in the case of CAHPS and other patient experience surveys, the thought is that people might feel like there's a pressure to please the person who's being asked and respond more positively. And so this would suggest that, for example, phone should have more positive responses than mail. But in particular, it suggests that it wouldn't just be about always or 10, but it should happen across the whole response scale. And then another thing that may be going on is recency effects. And the recency effect is more of a cognitive or memory kind of effect. And the idea here is that if you're reading things aloud, you tend to sort of hear that last option echoing in your head. It's a little bit more available to you. The first options on that list sort of disappear, if you will, whereas in a written form, they're all right there in front of you. And so this also predicts a more positive response, say by phone, than in a visual form, but it doesn't predict that that's what you'll see across the whole range of scores. It really predicts that it'll be concentrated on the last answer option. And when we look at this, we do find that all of these probably are both going on. The recency effects may be the bigger reason why this is happening. And there's sort of two bases for thinking that. One is we really do see the biggest effect on that last item. And then also there have been some studies, one by Rodriguez, where you can reverse the order option of the responses, and then you can actually flip the phone versus mail mode effects by making, say, never come last instead of always come last. Next slide, please. So, as I mentioned before, with the case mix adjustments, you can just derive those from your real implementation data. And so typically case mix adjustments are updated every reporting period and use the live data that you get to do that. But you can't do that same thing in the case of survey mode adjustments. And The reason is that you're exploiting variation at the patient level in case mix adjustment, but in the case of mode adjustments, a hospital chooses a given survey mode like phone only or webmail for all of its patients. And so unless you have an experiment, you can't separate out the quality of, say, the hospital from the effects of the mode. So imagine, for example, that the hospitals that are higher performing and better resourced use phone only more often than hospitals that are lower performing and less resourced, and they tend to use mail only. Well, without an experiment, you really couldn't separate that out. So what we do is we conduct experiments in which we have a national set of hospitals, and within every hospital we randomize patients to receive the survey in each of the different modes, and then we essentially and we build case mix adjustment into those same models, so that we're really just trying to figure out what's the effect of survey mode after you build in case mix adjustment. As I mentioned before, you don't need this when all the reporting units are using the same protocol. And then one other thing I'd like to say before moving on from this slide is that a lot of the protocols that are out there, including some of the ones that are proposed, involve a series of modes. So first there is mail, and then there's follow-up by phone, or first there's web, and then there's follow-up by mail. And in all these cases, we adjust for the whole protocol, not for the specific mode in which you respond. And one of the reasons that we do that is that the mode in which people respond is self-selected, and there's also are differences between people who respond early and people who respond late. So we actually get the best and most accurate adjustments by just adjusting for the whole protocol to which they're randomized. Next slide, please. Going into a little bit of an example for HCAHPS. After adjustment in HCAHPS, all hospital scores are equivalent to what they would have obtained in mail-only mode, which is the mode that we use as the reference mode. And sometimes people worry about mode adjustments and in terms of their scores. I'd like to suggest here that that's not the thing to do, because with these mode adjustments, your expected scores don't differ by mode. Your adjusted scores don't differ by mode, but there can be very good reasons to choose one mode over another, because some modes, particularly for your given patient population, can really improve your response rates and your representativeness compared to other survey modes. Next slide, please. Apologies that this will be brief, given the time constraints, but I'm going to talk a little bit about what's been proposed for the 2025 HCAHPS survey mode protocol adjustments. For the first time in the HCAHPS survey, protocols that involve a web format with email invitations have been proposed. We classify people as having email addresses made available to the survey vendor. That's EMA, or not, that's NEMA. And in developing these adjustments, we recognized that if you didn't have an email address, then you wouldn't receive the web invites. And so essentially somebody without an email address who is in, say, the web phone mode essentially gets a delayed phone-only approach, where somebody who does have an email address gets web followed by phone. And so we essentially create mode adjustments that reflect the protocol to which you are actually exposed. and that's described in the rest of this slide. Next slide, please. We essentially build regression models in the way that I described, and you essentially get an adjustment for the people with email addresses and the people without email addresses if you're a hospital that implemented one of these web-first modes. Next slide, please. Here, just for reference, are the adjustments that came out of that experiment and the ones that are proposed to be used starting with January 2025 discharges. The rows here represent the different HCAHPS measures, and you'll see that some of these are new measures that have been proposed for starting in 2025. The reference mode, again, is this mail-only mode. The red indicates negative adjustments, so you can see that adjustments for phone only tend to be negative. But again, that's because the same people respond positively by phone only, so that you can use mail only, you can use phone only. Your raw scores will be different, but your adjusted scores will be the same. You can also see that for the other approaches, the different multi-mode approaches, including the 3 web-first ones, the adjustments tend to go in both directions, and they tend to be small. And some of the intuition for that is that in a lot of ways, the web mode really is a lot like the mail mode in that they're both visual, so the adjustments tend to be small and not consistently in one direction. Next slide, please. So again, given that these adjustments are in place to ensure that the choice of survey mode doesn't affect your scores, a hospital should select survey modes to maximize the response rate, to maximize the representation of the population. Some of the things that we've learned, and some of this relates to a prior webinar, is that these multi-mode protocols outperform single-mode protocols, and that if you've got a younger and more diverse population, having phone as part of that tends to be really helpful. And if you have an older, predominantly white population, protocols that include mail, among other parts, tend to do really well. And there's a lot of promise in these web-first protocols, but really you don't tend to achieve those benefits of response rate and representativeness unless you get a pretty good rate of email capture. Next slide, please. And so I think, and then I'll maybe I'll just move a little bit forward in the interest of time to the next slide. Another thing that I'd like to mention here as we start to transition to questions and answers is that case mix adjustments and mode adjustments are not penalties when scores go down, and no more are they bonuses when scores go up. They counteract things that have already affected the raw scores and that are outside of the provider's control. And the goal here is to produce more comparable scores across reporting units than you could get with raw scores. And sometimes, if a hospital switches modes, you can see this in action, and we often see this in action. So if you switch from mail only to phone only, then typically what happens is your raw scores start going up, even if you haven't changed anything at the hospital, but your adjusted scores stay the same. And again, just to close with this, none of these adjustments are value judgments. They're just derived from the data about how otherwise similar people respond in the same hospital. Next slide, please. I'd like to briefly mention what the adjustments tend to look like in terms of magnitude. So typically speaking, mode adjustments have a bigger effect than case mix adjustments. And the reason for that is that even if mode adjustments aren't that big at the patient level, a given hospice or a given hospital has that mode adjustment applied to all their patients. So it's so it can be a bigger effect at the reporting unit level. Case mix adjustments typically are smaller because the adjustment is only about the ways in which your hospital or your hospice, say, differs from the average one. And so you can occasionally have big case mix effects, but that really is only going to happen for a plan or a hospital or a hospice with really atypical patients. It's also the case that in general, you tend to have a few reporting units with relatively large upward adjustments balanced out by a larger number that tend to have smaller downward adjustments. Next slide. And to summarize, careful case mix adjustment for patient level factors, things that a patient brings to the healthcare setting, can improve the validity and comparability of patient experience data, and can also importantly reduce incentives to provide to avoid some patients. When using when different reporting units can choose different survey modes, it's important to have mode adjustments to make those scores comparable. And that way, hospitals or hospices or other units can choose the survey mode that best ensures that they hear from as many of their patients as possible without having to worry about the net effect on the final scores. And reliable and valid patient experience scores are really important inputs to quality improvement and health equity efforts. And when they show disparities, when they show shortcomings, then the next step is for quality improvement, stratified reporting, payment policy, and equity focused incentives to try to close those gaps. Thank you so much.
Wow, Marc, thank you so much for a really depthful, but very clear and I think very useful, informative tutorial on case mix and mode adjustments. You have a very incredible gift for being able to explain those kinds of complex issues in a very clear way, which is precisely why we had you do this for our webcast today. So thank you again for that. We have a bunch of questions that have come in, and I'm going to invite Liz to join the Q&A at this point. And we'll start with the question. A number of questions have come in on the issue of the planned stay question being proposed to AHRQ 2.0. And Liz, I guess I'll just ask you to begin with, is that a final decision, or is it still kind of in a proposed state to be added to AHRQ 2.0?
So for the updates for HCAHPS, that would begin with January 2025 discharges. The survey changes are currently going through the rulemaking process. So everything's proposed and, it's not finalized it'll be finalized once that final rule comes out in August. So at this point, everything's in draft, proposed, and it's not finalized at this time.
And I believe public comment on the proposed changes are due sometime very soon, right, in June?
Yeah, it's due very soon.
Okay. Marc, do you have advice? This is a sampling design question. With respect to case mix adjustment modeling, is there a way to deal with non-response weighting or post-stratifying as a way of handling case mix issues?
So non-response weighting is typically used to try to make the respondents more like the full population. And case mix adjustment is typically used to try to make the respondents from, say, one plan more like the respondents for the others. And so they serve different but related purposes. In some of the, and it's often the case that the same kind of variables that you have access to for one, you have access to for the other. In a lot of the work that we've done, we've investigated whether non-response weighting helps with comparisons between reporting units. And we've typically found that it's not worth the variance inflation that you get. But if your goal is to specifically try to compare your respondents to your non-respondents, then it can be useful to do the two of them in combination. But I guess I'd encourage you to investigate that in your own data.
Okay, very good. There's a question about CAHPS, and the question is, what does the evidence say about how the new web modality affects the response rate for the other modalities of mail and phone?
So I'll give us that one a shot. So and I'll try to give it a broader answer, because I'll try to summarize a little bit across what we've seen with these web first surveys, survey protocols in M.P.A. and AHRQ and hospice, for example. And I think in all instances, we see two things going on. The first is you get some responses from people who wouldn't have responded at all. So there's a contribution to increasing the overall response rate. And then you also tend to get a bit of substitution. So some people, because when we do these web first protocols, the web always comes first. And in some cases, you get people who would have responded later, say by mail or phone, but now they respond earlier. So you tend to get a small decrease in those later modes, but it tends to be smaller than the number of people who respond by web. So you kind of get a net increase, but also a little bit of substitution.
Okay. Of all of the variables that you've reviewed, Marc, for case mix adjustment, language clearly is an important one. Liz, this is a question for you, because the question is whether CMS could possibly require hospitals to administer HCAHPS in multiple languages, because not all vendors appear able to do that or willing to do that.
So for HCAHPS, and this has been finalized already, we will require all hospitals and survey vendors to administer the survey in Spanish, starting with January 2025 discharges. For all of our surveys, this is beyond, HCAHPS, other CAHPS surveys. We do strongly encourage that, providers or plans work with their vendor and, use those translations when they can. I know some, are concerned about the cost of it, but to help you increase response rates by, doing the survey in the preferred language of the respondent. So instead of getting a non-response, you get a response. The other thing I would strongly encourage, the costs across vendors differ. So, if one vendor says that they will not, administer in a particular language, shop around, because for most of our surveys, there are multiple vendors that can administer the survey.
Right. Okay. Thanks. Very helpful. Marc, this is a question related to the mode adjustments, and it comes from a vendor wondering whether there would be a vehicle similar to the CAHPS SAS macro. You might want to explain what that is, that users could apply to and sort of make the mode adjustments to the CAHPS surveys kind of automatic. Is there any sort of vehicle or tool that will be available to help vendors and other users do that?
So I'll start by just briefly describing, as you suggested, Dale, the CAHPS macro. So the CAHPS macro is a tool that both scores CAHPS surveys and also implements case mix adjustment. I don't recall, I'm sorry to say, whether there's an option that would allow you to insert the mode adjustments into that. I will say it is the case that for all of the, say, CMS implementations that use mode adjustments, the mode adjustments themselves are available on CMS websites, and they are, you know, fairly straightforward to apply, and that they typically apply to in the same way to all patients in a given hospice, say. So I'm not certain that that's built in as an option, but I think that the CMS resources nonetheless would be pretty helpful in doing that.
Okay. So Liz, with respect to CMS resources, and Marc presented sort of the list of variables for various CAHPS surveys, is there a kind of a one-stop shopping place where users can go to see the various case mix variables that are used for the different CAHPS surveys?
Sure. So on our website, cms.gov, if you go to that website and then the search, just enter CAHPS, the first option that will come up is a web page that lists all the CMS CAHPS surveys, and there are links to all the project-specific websites, and each project-specific website has information about the case mix or patient mix adjusters and what those adjusters are. That information is, if it's a survey that's updated quarterly for public reporting, that information on the website is updated quarterly. If it's a survey that's done, for example, annually, it would be updated annually. But I encourage you to go to that page and then just follow the links for the particular survey, to get that information.
Great, very helpful. Thanks, Liz. So time for just maybe one or two more questions. One, Marc, to you has to do with other adjusters, for example, for social determinants of health. Are there ways to go about collecting that information to use in addition to the variables that you've described?
Sure. So I think conceptually, social determinants of health, are a great example of something that patients bring to the setting, and so they are potentially good adjusters. Sort of two considerations come to mind. One is you'd need to think about how they'd be made available. Some case mix adjusters are available administratively, and if that can be done, then that's really helpful, because you don't have to spend survey space on those. So, for example, age can be collected administratively, and so anything that can be collected in that way, it's especially easy to incorporate. If there are things, a lot of things are brought in through the survey, and there, those items could potentially be added, with survey length always being a consideration. And then once you had access to those measures in a way that was linkable to data, you then need to go through the usual evaluations of whether they're predictive of scores and contribute in a way that goes beyond the existing adjusters.
Right. Very good. We are out of time, and I just want to sort of help us conclude by, first of all, thanking you again, Marc, for an excellent review. Liz, for your participation, clarifying CMS's responses to these questions. I'm sorry we couldn't get to all of your questions, but let me move on to the next slide and let you know that there are resources that are continuing ongoing. We send out periodic news alerts, information about what's going on with the CAHPS program. You can sign up for those email updates very simply through this on the CAHPS AHRQ website. You'll be able to hear information about these kinds of events, and we have one coming up actually tomorrow on the HCBS CAHPS survey and how to participate in the HCBS CAHPS survey database. We also have a research meeting coming up in September, and you'll be hearing more about that in the coming weeks with a save the date. It's a research meeting that will address the relationship between PREMs, patient-reported experience measures, and PROMs, patient-reported outcome measures, and certainly I think will be of interest to many of you. Next slide, please. Again, if you have further comments or questions that you didn't get answered today, you can always email us at CAHPS1@westat.com. The 1-800 phone number is also listed here. And there is an enormous amount of information resources on the CAHPS website at www.ahrq.gov/CHPS. Okay, we're at time. Thank you again to Marc, to Liz, to John for kicking us off. And thank you all for joining us today. We wish you a wonderful rest of your day. And please, as you exit, if you have a minute to complete the webcast evaluation, we would really appreciate it. Thanks again for all of us, and we'll see you next time.